Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Welcome to the Concussion Corner podcast. My name is Dr. Jessica Schwartz, and I'm thrilled to have on today with us a board-certified sports clinical specialist and Doctor of Physical Therapy, Dr. Jason Hugentobler. Dr. Hugentobler is a physical therapist on the orthopedic and sports team at Cincinnati Children's Hospital. He received his master's degree of physical therapy from the College of Mount St. Joseph and his doctorate of physical therapy from the University of Tennessee. Jason completed the sports residency program at Cincinnati Children's Hospital in 2010 and received his board certification as a sport certified specialist from the American Physical Therapy Board Specialty Program. Jason has served on evidence-based practice teams, lectured regionally and nationally on multiple topics including the overhead athlete and concussion. Dr. Hugentobler also serves as an adjunct professor at Mount St. Joseph University, teaching the concussion special topics class. Jason, welcome to the Concussion Corner podcast.
Thanks for having me, Jess.
Oh, I'm so pumped to have you on. You know, our listeners, don't know our relationship, but I saw you speak at CSM. I want to say, was it in Indy? Was it 2015? I think it was.
It absolutely was, yes.
Oh, man. And, as we're getting ready for CSM now, combined sections meeting, we have 16,000 physical therapists from all over the world coming in. And, I just can't, put the emphasis on of the relationships and rapport that you can, get along with at these conferences. So it's a pleasure to have you on.
I think CSM every year is the thing I look forward to definitely the most. And yes, I remember vividly after I got done speaking in Indianapolis, you coming up and approaching, and man, from there we just hit the ground running. So great to be with you.
I think I was like the Micro Machine Woman. Like I was like, we need 15 minutes. Let's make it happen. And
yes, you set a timer on the table, and like we just back and forth. It was like unlike anything I've ever been in. So
welcome to the world of Schwartz. All right. So, just for our listeners to kind of connect to, so Jason, we've got listeners from all over the world, from Australia to Ireland and all over the United States and everywhere in between. And, the Concussion Corner podcast is really encouraging that free open access medical education, that foam ed movement, and just trying to shut down that knowledge translation gap, especially for the world of concussion. And we know that, 14 to 17 years on average it takes from once white paper is produced to actually practicing in clinic. And so I really would like our listeners to lean in, deeply listen to Jason, or Jay as I like to call him. And, he's just going to have so much to offer. So let's get this thing kicked off, Jay. So, I always start the podcast off with someone's why. And I know that we're going to do a ton of these in the future, but, for this episode, for folks to connect to you, as I've been lucky enough to in the last few years, I'd love to hear your story of why, how you kind of wandered into this world of concussion, and kind of take it from there.
Yeah. So great intro, by the way. It's amazing you were able to squeeze in the APTA's new designation of how we have to say our board certified clinical specialist. That was impressive. So my story really began in grade school, high school, college. I played football. I played multiple sports. I got concussed. Back then, I think the designation, or at least what I was exposed to, was you had to get knocked out in order to get a concussion. And there are 4 times I remember thinking of it. And when you asked me to talk about this podcast, there were 4 times that I was knocked out of a game. And one of those times I actually stayed in. And I think that in addition to just my exposure to physical therapy and really the vast array of specialty niche areas that you can get into. And when I chose the sports world, and when I was actually the resident here at Children's Hospital, concussion was just blowing up. I mean, you had the NFL, they were being sued for billions of dollars. Concussion was the hottest topic. And my residency director at the time, Mark Paterna, who is like the ACL guy, said, what do you know about concussions? And I said, hey, Adam, let me tell you about my experiences with it. And so it started in residency year. I was working with a local D3 football team, Thomas More College, And at that time, we were still looking at some of that return to play, that evaluation piece. And we were really big into balance measures. Best testing was big. Force plates were just starting to become much more affordable. They weren't quite the expensive piece of equipment that it was for just lab settings. It was really the clinical utility of those was starting to become more popular, especially with the Wii. And so my first project in it was taking and balance testing all these athletes and putting them on force plates, having them do the best, and then seeing as they went through the year how some of those changes happened. And actually, I presented back in 2011 at CSM in the sports residency platforms section on some of my work, and even back then, it's showing what they're seeing now, some of these differences in movement patterns for athletes after concussion. And I know nowadays they're tying it to, is there potential for like lower extremity injury risk and things. And the work that I was doing back then was highlighting some of the work even done before me. And I think it just shows like after concussion, there's definitely still some impairments there, and it may be subtle. So like I said, it started back then. We took stock in what we were doing as a hospital. Really, the physical therapist role was just in the balance assessment. The doctors would think this athlete has concussion. They'd send them over for some balance measures. We'd send them back with their results, and then the only time they would see us would be if they had like neck pain. If they had neck pain, we'd be treating them for that. And as I dug into the literature back then, as a resident, I had time to be able to do that. I said, listen, guys, we're behind the 8 ball. There's things being put out by people that are saying we need to get these kids exercising, that there's a subset of these kids that are going to have problems. And all of a sudden we started to discover, yeah, there's kids within our system that are having these prolonged symptoms, and they're tying it back to this specific mechanism of injury. And all of a sudden, like, here it is, this is our guy, and I kind of got thrust into a situation. And so thankfully I had great mentors, and I have no problem reaching out to people and saying, hey, help a brother out. And having my own experiences with concussion and being able to just relate to the patient, like, yeah, I remember how challenging it was trying to get back to school. My last concussion, actually, I was in grad school. I was in PT school. And I remember my neurology professor, of all professors, was the only one that kind of gave me a little, laxity as far as my classroom attendance and letting me sit back in the back, because she understood. But my other teachers, my ortho teachers, they had me stay on the grind and really work through some of those things. But yeah, so I started to work with these patients. I attended everything I could. I tried to soak up as much information as possible, and I started to find my groove and listening to and applying some of the evidence there. And then eventually we kind of started our own program here at the hospital, which was evidence-based and really saw our numbers explode to where in 2015, I saw over 50 kids myself just for a concussion evaluation that we actually captured as far as a PT visit. There's a number of times I get pulled into next door, whether it be sports med or a PM&R doc, just for some consults on some patients and triaging them, because we get kids that they come from all over the region and potentially all over the world. And so there may not be an opportunity to do a true PT assessment. So since then, I've been fortunate. I've worked in and participated in a number of research studies looking at some of our own techniques, our own processes, and then other research avenues, and trying to improve what's out there in the literature. And we've been very fortunate to publish a lot of good work, especially with my colleagues, Dr. Quatman Yates and Dr. Kurowski. And it was actually Dr. Kurowski that was speaking with me in Indianapolis. And then you even remarked just how, like, from a physician standpoint, like, he got it. Like, he understood the multidisciplinary approach that was needed, and it was great to have a physician out there. So, so yes. So now I'm sitting here. I've got a top conditions team that our division has invested time and resources into. I have several team members from both inpatient and outpatient that we're trying to tackle TBI as a whole across the entire spectrum, but also right now we're really focusing on our efforts on concussion, because again, that's the largest animal, that's the largest number of patients that we serve within the brain injury spectrum, and really that's what's going to help carry us into treating the mild traumatic, the moderate, and then the more severe brain injury side. So.
Indeed. And, I think that's such a common theme, just to comment on a few of your talking points there, Jay. you know, everyone that's come on has essentially created something from nothing. And, that is essentially the theme. And what's so beautiful, at least for the theme of 2018, it got a little hairy, there's some toes were stepped on in the last, 15, 20 years. But in the theme of benevolence in 2018 amongst concussion healthcare providers, researchers, clinicians, scientists, and so on and so forth has just been amazing, because we have to be able to impart what into the rest of this world, right?
Yes, absolutely.
And yeah, it's just amazing. And, just like you said, you were just entering in with balance measures and force plates and vests. I was the same thing. I actually did my doctoral level thesis, and I think I was at the 2009 Next conference in Baltimore. And we did a poster. We made a poster, and that was the only thing I've ever postered on. But it was actually, I think, the first published or second published thing on the Nintendo Wii, the Wii Fit. That was
Yep.
the year it came out. And
Yep.
I was looking at elderly and falls and executive functioning of all things.
Yep.
So we used the exit 25. We had to have like clearance, going through all the people for the clearance to do an exit 25 because it was a psych measure, and we got
Wow.
clearance. And yeah, talk about full circle. But I think what a common theme is our listeners will connect to is that basically you don't wait around. There's no reason to wait around to wait for something to arrive to you. A lot of, I think it definitely was. It was Erin Reynolds, Dr. Reynolds, our neuropsychologist that we've had on. I think it was for episode 5 or 6, and she essentially said, she's like, you have to actively initiate this post professionally. This is not something that we're getting entry level. Dr. Kutcher on our first 2 episodes, we talked about it. Or openly talked about it because it needs to have the conversation. Is that 2015 was the first formal didactic year that neurology physicians had training in concussion. So this is not
It's
something that
unbelievable. Yeah.
we have at entry level. Anything, whether you're a neurologist, physician, DO, MD, DO, physio, neuropsychologist, OT, PT, whatever it is. This is something you have to actively initiate post professionally and create. And just kudos to you.
Yeah, it's definitely. I mean, you hit the nail on the head. When I guest lecture for the PM&R residents over at the University of Cincinnati. I've been fortunate to be invited back the last 5 years because they find a lot of value in the things I'm teaching them or instructing them on, because they don't know what physical therapy does, and then physical therapists' involvement in concussion. I mean, they soak up everything I have, and they take a lot of like clinical pearls and takeaways that help even with their exam. And just this past year, I remember some of the residents that were there the previous year, because they invited me back early this year. They said, "Oh, we use some of that testing that you taught us last year in clinic all the time, and it's amazing the things we're picking up on that we just weren't sure of." And yeah, if you sit back and wait, it's gonna move by you, because gosh, especially in concussion world, everything is changing, and you really got to read it with a critical eye, because it seems like there's a million things to do. And on the physio side, we have several minutes to an hour, if you're lucky, at the time of evaluation to get everything we need to then start these patients on their path to recovery.
Indeed. And if we're just looking at this, I just spoke with Dr. Lenore Herget out of MGH on this, and she's, physio for like every Boston team and MGH, and she's just one of my top 5 favorite physios, including yourself, in this world, for concussion. And, we just talked about this the other day, and if you're looking at, everyone wants a clinical prediction guideline, right? You're a sports guy. I'm an ortho chick. I came up through ortho residency. You came up through sport residency, right? So at the end of the day, this isn't an ortho thing, a neuro thing, a sport thing. This is an everything injury, and you have to be all hands on deck here, and you have to be able to screen comprehensively, looking at cognition, mood, somatic orthopedic and neurological injuries and things like that. So you really have to be all in on this. And this podcast was started because I truly believe, not only as a provider, but as a survivor as well, and a thriver at this point, that the mismanagement of these patients is much more prevalent than the well cared for concussion patient of today. And if we're looking at the UPMC clinical trajectories, they're seeing about 20,000 patients a year there. And the good work that they're doing is that they're publishing, they're putting information out there for the world. And if we're looking at their 6, and I'll add a 7th of autonomic and exercise dysfunction, if we're looking at, exercise and autonomic dysfunction, vestibular, ocular, motor, post-traumatic migraine, and the cervical spine, and then altogether, anxiety, mood, and cognition, of those 7 trajectories, 5 of those are right up the physical therapist alley. So if
Absolutely.
the fact that,
Yep.
we can do comprehensive targeted physical examinations, and then we can see folks, 1, 2, 3 times a week, it's just a beautiful from a rapport therapeutic alliance value standpoint, and, to have these folks with some skilled care. What are you seeing, over at Cincinnati Children's and the Children's Hospital, in terms of how many providers are folks coming, like, seeing before they see you? And what are some potential, mismanagement things that are going on? Of course, there's a place to build up, not tear down, but what are some common themes that you're seeing?
Gosh, I mean, we could talk for hours on that. I think I'll start with maybe where we started from. When I first got into this, I would see kids that they would be coming in and they'd be 2 years post injury and looking for something, and it might have been as easy as they've got a cervical facet dysfunction, they've got some cervicogenic things going on that just through some targeted cervical therapies, they were able to get rid of not only their headache but also some of the dizziness associated with it. And here they went through the line of medications and the migraine courses, and it was helping with some of the migraine headaches. But they could explain, they could clearly delineate the difference between their migraine headache and this other headache that they got that they just couldn't explain. And so kind of fast forwarding to now I get referrals from our headache center for kids to help with that, because they recognize, not everything can be just managed with medications. As far as what we're seeing here at the hospital, again, because we serve such a large area and we have people that come here where sometimes their second or their third consult and they'll travel large distances, we'll see kids that are still several months to even unfortunately years removed from their initial concussive event. And the amount of the education that goes into this and instilling a little bit of resiliency into them, like we know you're 2 years in, but here's a potential path to recovery. It takes a lot of investment, time invested, resources to be able to do that. I'd say for our local population, because of the popularity of it, I would say people are definitely being a little bit more forthright about reporting their symptoms, which is good, because it does everything we do treatment wise, unfortunately, is symptom driven. We have to have that rapport, that relationship with our patients, that listen, when I'm going to expose you to some of these things, I need to know how you're doing, because for some of our treatments, for some of our intervention strategies, we're going to dip our toe in the water and make you a little bit more symptomatic. But then there's that other side along the physiologic side where they're on sub-symptom threshold range. And so really helping them to understand, like, you need to pay attention to these kind of guidelines, these rules, and the education I'm providing you so that we can have a safer recovery. I think it's getting better. The one thing I notice on the side, especially in the youth athlete, is even though coaches are required to attend whatever the state mandates as far as their concussion awareness, and even the athletes that sign the form, just 2 weeks ago we had an athlete that got a concussion on Tuesday, and he told the trainer he had a headache later that day. He thought he was going to play on Friday and was willing to almost change his story to, oh, it's because I didn't eat that day, just so he could have a chance to play. And the coach is talking to the trainer and trying to get in. So I still think in that realm, especially with high school sports and the energy, the emotional investment by parents, by coaches, by players, I think that acute return to play thing is probably where, as providers and as professionals, we still have our work cut out for us as far as managing this population.
Indeed. And are you seeing any providers, because this is what I see often, is that they're prescribing rest, right? They're still back on those 2004, 2008 guidelines, where the old guidelines stated that, we're going to rest until your symptoms completely abate, which we now know is incorrect in 2018, and that we want to get these guys up and moving under skilled guidance with a pace-graded exposure. And we can talk for days on what all that means. But what are you seeing in terms of folks that are outside of your network referring in that, have been told to rest for like a year plus?
That's exactly it. Within the hospital, if they come in through our doors and we're the first providers that see them, they don't have any more than 48 to maybe 72 hours of rest before. Even then, they're trying to say, get up and move, do some light exercise. There's no more staying in a dark room forever or stay sleeping forever. It's definitely a little bit more kind of in line with what the new guidelines are recommending. But as you get out into the community, and especially pediatricians, primary care providers that are being asked to manage and triage this exploding population of patients because of the awareness, I think they're starting to recognize, definitely within the last year, that kind of learning from their mistakes of, gosh, if somebody's not recovering sooner rather than later, I need to get them to somebody that maybe has a little bit more experience to them, and so they're coming into our doors, or they're taking maybe the initiative to attend some of the conferences and things that we put on, some of the grand rounds that we have, so that they are better prepared to understand what are the different treatment strategies for this population, to not have them sink into the pitfalls of too much rest, and all of a sudden it's been a week or two, they haven't moved, and now it sets off this sequelae of other potential problems going on for that person, all set up by the initial intention. Like you said, I'm trying to do what's best for you, and what I was trained in was rest, and now all of a sudden it's all of a sudden recognized as not the staple treatment of choice.
Right, and especially being a board-certified sports clinical specialist with the American Physical Therapy Association, I'd love for you to comment on what the differential is between return to activity and return to sport, because I think what a lot of people interpret that as, the old way of thinking, and that was published in the international consensus, was, you rest until symptoms abate, which we now know is actually harmful to mostly all patients out in this world, which we've seen historically with low back pain, even cardiovascular, like myocardial infarctions. We now no longer rest heart attack patients. There's no need to rest a mild traumatic brain injury synonymous with concussion. Historically also in the ICU, we're getting up mod and severe TBIs, traumatic brain injury patients, as early as possible. There's no reason to, rest a closed head injury, longer than 2 to 3 days. But I think what folks have a difficulty understanding, that aren't in the rehab world, that may not be a physio or board certified in sport or ortho or neuro, what is the difference between return to activity and return to sport, and why is that so important to connect to?
Gosh, again, you're laying some pretty good questions out there. It is definitely a question we get from not only providers, but also from the patients and their parents, because you'll have one end of the spectrum where these parents want to wrap their kids in bubble wrap, and they fear them walking out of our doors. They fear them getting into the car and bumping their head. They fear them going out on the playground. And then the return to sport, which is, we have to be honest. We take into consideration everything as far as the risk factor of that person going back to sport, right? We have to recognize that somebody going back to football is maybe a little bit different than somebody and swimming. They may present the same. They may have very similar trajectories as far as their recovery, but the risk factor is there, especially when you start to look at their concussion history and how long each of those patients start to recover from maybe prior concussions, and it starts to give you this profile of this athlete, and you can kind of almost predict how long it may take for them to recover. So getting back to your question, important to remember, and I know you hammer this home with a lot of people, that return to learn component. I try to talk to people. It's kind of like a balancing scale. It doesn't make sense to your teachers if we are giving you all of these assistance at school with some of the return to learn, but I'm telling you, oh yeah, it's fine to go back and play your basketball game. Like, there's a mismatch there that shows that we're not ready cognitively yet to be able to handle that load, and we're maybe putting much energy or emphasis into some of the sport and activity, but we need to find a balance there. We need to make sure that we're concurrently working on both of those systems and helping you can tolerate more full days of school and that cognitive load, as well as the physical and emotional load. And so when you start to bring it to that perspective and show them how those things really have to come together, and that when there's a mismatch, it can actually offset the entire system and really have it crumble underneath them, then you get a little bit more buy-in and understanding from the patient, from the family, of activity is good. We need to return them to activity sooner rather than later. Return to sport, it depends on the intensity, the type, again, that risk factor, and a lot of times that will determine maybe what that return to sport decision making looks like. And again, from a provider standpoint, we try to make sure that we cover our end. We make sure that we are adhering to and abiding by those guidelines and those tests, those things that have been shown to. We expose them to it, we retest them, and we need to see improvement in some of these things so that we're just not, oh, they seem fine or they look good, and so we're just going to let them go back. Like, we need to have a little bit more critical eye under these kids and make sure that we're having them pass some of the testing that we exposed them to early on, if we happen to have baseline testing or anything else, to make sure we're making better and more informed decisions.
Indeed. And, you said a few important things there. We will have, actually, she's already interviewed up. Your podcast is going to launch before hers, but Brenda Egan-Johnson, who's basically an expert in return to learn, formerly Brenda Egan-Brown. She's now Brenda Egan-Johnson. She officially changed the name. But, the return to learn before return to sport is so important. And with return to activity before return to sport, we have to make sure that we are getting the information out that low load cardiovascular activity is a good thing for everybody, including, TBI and concussion patients. And the fact that, we don't go from laying in a bed for 14 hours a day to, going back onto field or going back to work or going back to school. So that's so important to say, hey, well, did you get out and did you walk to the mailbox today? Did you check the mail? Did you go walk down the block? Did you, do something? Did you try and, X, Y, and Z? And we can talk about pace-graded exposure on a different episode for 30 minutes. But, hitting those short-term goals to, get that long-term goal. And a lot of folks outside of rehab don't understand what that means because we take for granted, feeling well in our daily environment of school, work, home, family, the whole nine.
Yeah, one of the toughest cases I remember from a few years ago, I had an athlete that was involved in a car accident, very high achieving type A. He was going to an Ivy League school on a swimming scholarship. And you talk about swimmers in season, the training regimens that they're under, they're going to practice before school. They go through school. They're going to practice after school. And it's kind of like runners and swimmers, very similar patient populations, right? If you tell them they can't do something, that they can't do their sport, the thing that they are just driven to do, it all of a sudden sets off this thing of like self-doubt and depression and anxiety and worry, and you're taking them out of their routine. And with this case in particular, when we return that individual back into the pool, his symptoms would reduce. He had the emotional domain start to calm down. His fear started to calm down. His headache started to get better managed and more under control. He just felt better, even if it was just at short intervals and doing it in such a way that we were trying to make sure we paced him back in and just didn't return him, like you said, to what he was doing prior to injury. All of a sudden, the recovery trajectory just took off, and this kid was so much better for it. For him, it was a challenge being a swimmer. Like, I had to really work hard. For those first 2 weeks, I was working on his neck constantly because from the car accident, a lot of things that he was having some cervicogenic headaches and dizziness from it. And so we hammered away at some of those things. And when we worked in the water, we had to have him work with a snorkel so that as he was exercising, we weren't confounding some of those physiologic. That was something that we worked into his plan that, again, as a sports certified specialist, you got to know the demands of the sport. What are some of those things that you can use to help them achieve what they need to do, but also not jeopardize evaluating thing or physiologic thing? And I think that's a great case, a great illustration of really recognizing what these patients need and, again, what it did for that patient as far as his recovery.
Indeed. And, there's such great talking points, Jay. I was wondering if you can let our listener into, what are some issues that you're seeing as a physical therapist with, parents and return to school? Are you, how are you getting involved in that way?
Yeah, thankfully our hospital has invested in some school interventionalists. So we are fortunate, especially in our concussion clinic, we have two former teachers that rotate in and out, and they handle and triage a lot of that information. They have great reputations within the city with a lot of the teachers because of various positions they've held, and they know a lot of the teachers, the administrators, the principals by name even. And so they really work with them to make sure that they're doing what's best for the child. And then my job is what happens on my end as far as physical therapy. We try to structure our visits, and we try to schedule them accordingly to where they are as far as their return to learn. depending on their symptom severity at the time of injury, which a lot of studies have shown, the worse you are at the beginning, potentially the longer term you're going to take to recover. If these kids are battling back through half days of return to learn, or they're starting to ante up to, more gradual return, 75% even, if they still have a hard time with eating lunch in the lunchroom and some of the you got to come in the morning if you can on the days. Maybe you have a late start for your return to learn, or you come in the early afternoon before our clinic gets busy. That way it's a great session for you. It allows us to spend more time with you, and it sets us up with a great environment to allow you to be successful with what we need to tackle that day. And then we set them up for, another stepping stone that we need to get through is having you be in the busy clinic to help you get acclimated to and adjusted to some of the sensitivity to the noise, to help with the body's resilience to some of those things, but doing so in a very appropriate way that we are monitoring what your kind of in-session responses are, and then what those responses are as you would leave here, because, again, the body's going to tell us whether we were successful at dosing that or not. And so I think from a return to learn standpoint, thankfully, I don't have as much say in some of that. I'll help them with some of the accommodations and some of the things we recognize in our exam of why they have difficulty looking at the board and then looking at their paper, why they're having some challenges with some of the reading, and then assigning some of the interventions to help with some of those things, as well as just posture. Again, especially if they have a cervicogenic component to them, that's where I think some of the things that as physical therapist, especially from the MSK side with your ortho or sports, you can help and recognize some of the things that the cervical spine and poor posture, poor positioning and things, poor planning really on our part and that of our patients, that set them up for headaches that are coming on maybe sooner than what really need before that cognitive load is even touched, because we're in poor posture, we're laying down on our tables, and we're not setting ourselves up for success.
Indeed, and there was such a great article. As physical therapists, we talk about kinesiophobia all the time, which is a fear of movement. So that fear avoidance behavior, and that is a behavior, and it impacts lifestyle and profession and familial and social lives. Grant Iverson, just out of MGH in Harvard, just published a great article on cognophobia, which is an MTBI and concussion, which is, again, is what we see. People become fearful of cognitive behavior. We have to remember that our brain is an only child, and it's very selfish, and it's very blood and glucose hungry all the time, using about a third of 20% of our energy. And that, even just yeah, exactly. All the, and the ocular motor system just in itself, the brain's pathways for vision are about 2/3 of the brain's pathways are devoted to vision.
Oh, I know it. We're visually dominant, animals we are, yes.
That we are, So what are you seeing? We have about 3 to 5 minutes before we wrap up, but what are you seeing in terms of ocular motor and visual disturbance in your post-concussive patients, especially, behavioral things with your peds patients, because, again, they don't have the subjective language to express the what and how they're feeling.
Yeah, that's the piece that for concussion we'll talk about it, but also across traumatic brain injury. The ramifications of having a student athlete, a patient who starts to self-select themselves from participating in class or things because of some of the challenges that they're facing and maybe not willing to speak up, that then what it leads to years down the line is now they're further behind in school and in studies, and maybe causes other social behavioral issues down the line. Like, we're trying to discover those things much more on the front end to arm these patients with information, education, and interventions to help them. And thankfully, again, there's been this swing, this recognition within some of our providers, because at Children's, we operate as physiotherapists, we do not have direct access. We have to get a referral from a physician, within our institution.
In your hospital, yes.
In our hospital, yes. And our providers have done a great job of recognizing the complexity of that evaluation and recognizing the importance of the eye. I think every one of our sports medicine doctors, our PM&R doctors, our neurology doctors, they recognize super simple, easy tests that they can administer to try and get down to, do they have some of that oculomotor dysfunction, and what can we have them do? Even so much that I have generated some handouts, some educational material and intervention material that when these come in, they're giving these to patients if they have any convergence insufficiency or anything that they're picking up with their King-Devic scores or anything like that, because honestly, there's no harm in dosing them. If a subset of those patients, 80% of those patients are going to get better anyway, whether they have those interventions or not, but you could potentially keep of that 20%, you could keep them from having persistent symptoms for a long period of time because you took care of just one simple maybe domain that would have set off this cascade of other problems down the line. Why not do it? And so they're having these kids do some of these exercises, which again, as a physical therapist, they're taking some of that out of my realm a little bit, but they're recognizing that there's problem, trying to get the hang of it. And then if they're not getting the responses that they would expect in their follow-up within a couple of days to maybe a week from these kids, they try to get them over to physical therapy as much as possible, which again, thankfully, we have seen a shift. I mentioned we used to see kids that were several months to years out. Now I had a child who was referred to me. It took her 7 months to recover from her last concussion. She came into the sports med doc 3 days after injury. The doctor knew her profile, her portfolio of all the problems that she had before. Right away, she said, go into CPT. We're going to get you into this clinic. We're going to get you into neuropsychology. And we're going to get you into our biofeedback center for some of the coping strategies, some of the things that were discovered, unfortunately, late in the game for her the last time, which was 3 years ago. Mm-hmm. So there is this internal learning system that people are recognizing. And I am thankful that, especially for the ocular motor system, our frontline providers are aware of that. And so as much as far as deficits, but we are able to take what little success they've had and then help them hopefully reach the end a little bit quicker.
Indeed. And, Jay, as we wrap up shop here on time for at least this episode, I know we're going to have you back on. We're going to talk about what an actual American Board of Physical Therapy residency and fellowship is. Specifically, I know you just interviewed your sport resident for 2018, which comes in for the summer. But I was wondering if you could just kind of give the listener just like a 30 to 60 second blip of, hey, what is a sport residency at your site, and, what that entails, year long, so on and so forth.
Yeah, just globally, I think residencies are great for those clinicians that want to have that mentorship, that deeper understanding, that deeper level commitment from people that will invest themselves in making them better clinicians. And that's really what at the heart of the residency and fellowship experience they're trying to get to. Residencies allowed you to train in specific areas. You mentioned sports, ortho, neuro, et cetera. And then fellowship even narrows it down even further into a very specific thing that you want to tackle. But here at Cincinnati Children's, within our sports residency, again, we're kind of a niche sports residency in that you're going to deal with the pediatric athlete. The minimum requirements are that you have at least 40% of your patients are within the athlete profile. We're fortunate we have about 70 to 80% of the patients that you're going to see are going to fit that athletic profile. And then there's a number of on-field hours, which is specific to the sports residency versus orthopedic, that you have to get with an athletic trainer, with some acute care management, and really being on the field and seeing these athletes from the time of their injury to back in the training room to potentially having follow-up with them back in the physical therapy setting as well. And it gives you a deeper appreciation for really the decision-making and some of that very fast on the field management that needs to be done. Can they play? Can they not? Are they hurt? Are they injured? And triaging that and recognizing some of those major red flags that you will experience, to then in the PT setting where we have much more time to dig into some of the special tests and some of the other things. So our experience is unique. Again, we have the pediatric population, the youth sports population. Our on-field coverage is done with a local Division III college, Thomas More University. So you will get some of that high school to collegiate athlete as well. And then we're also fortunate to have a very good research arm. We have research projects every year completed by our residents, led by our scientific director, Dr. Mark Paterno, who specializes in the ACL. If you've ever read any ACL work, I can guarantee Mark's been on a number of those publications. And then we also have now a teaching component, because we really want to by the time they graduate from here, we want to have a stamp on them that says they can tackle anything. They can go and be a part of a faculty. They can go and just apply for research projects. They can pursue their PhD, or they can be recognized as that master level clinician with 5 years experience within 1 year's time and have all of this training to, again, be the best provider they can be and really be a jump start into what they want for their career.
Indeed. And you know, when I went into residency, when you did in 2010, and from 1999 to 2010, I think there was like something like 13 or 1400. I think it was like 1400 and change residents since 1999 that were physical therapists in this country of the U.S. I think today I'm looking at the AB PTRFE website, and today the number of graduates from 1999 to 2016 are 3,200 and change. So again, these are folks that are, you know, aggressive, they are interested, they are connected to learning, and really just wonderful to promote. I'll close up this question for you as we sign off, before we give our listeners your contact information. Where do you see in the next 3 to 5 years, where do you see the physical therapist in the chain of command, for this injury of concussion management?
Again, I think physical therapists are uniquely positioned to have the time to spend with these patients that, as you illustrated, several of the dozen domains and areas that these patients can have deficits in, we really do have the training to tackle several of those. I think you mentioned, at least 5 of those fit within the scope of our practice. And so I really truly see our profession helping, and again, we can't do it alone, we recognize that, but really helping to push concussion management, concussion evaluation, concussion treatment, concussion prevention even. Is there something we could do to reduce the risk? Pushing that forward, and over the next 3 to 5 years, I think, again, physical therapists are going to be invited more to these boards, these committees, these expert panels to help with some of that decision making. Because, again, on the front line, we're the providers that are trying to help, especially that post-concussive group, to try and get back to their function sooner rather than later.
Indeed. I love it. And, where are some places that folks can reach out to you, whether it be social media or email or whatever you're comfortable with, Jay?
Oh, you know what? I get crap all the time from my patients that, Twitter's for old people, they tell me, and I say, no, that's where I get a lot of great information. I follow you, I follow a number of other physical therapists on Twitter. My Twitter handle is @JAH_sportspt. I usually shamelessly plug myself when I do these different presentations because, every now and then I get a little wild hair and I decide to tweet out a bunch of things, retweet some things. I've just gotten into doing Instagram. I couldn't even tell you what my handle is on Instagram. I'm on Facebook, but honestly, my Facebook is about showing all the the guy. I love my family, and keeping up with birthdays. So that's what Facebook has turned into for me. Again, another one of those, as my patients say, one of those old people things. So
Facebook is strictly personal for me, and I keep everything professional on Twitter.
Jess, we did a poll in the clinic, and we had all the patients fill out what their top 2 favorite social media platforms are, and Facebook got 1 vote, Twitter got 2 votes, Instagram, Snapchat, and even Pinterest. And this other art one, I can't even tell you, I've never heard of it, got more votes than Twitter and Facebook combined. So it was super funny. Our patients loved it. They call me old. It's fine. I got the gray hairs to prove it, kids.
That's okay. We put in our time to earn those guys.
Yes, you got it.
All right. Well, I look forward to having you on. We'll definitely do a whole talk on, residency and what that is for physical therapists. And we'll definitely have you on. I really think we'll dive a little bit deeper and talk about some complex cases and kind of what you've experienced and how you've kind of gotten through those. So again, thanks so much for coming on to the Concussion Corner podcast, Jay.
Jess, thank you very much for having me. Appreciate it.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.